So our final speaker is Jessica Peters, and she's a dietitian based at Royal Melbourne Hospital. She specialises in patient care associated with gastrointestinal and metabolic disorders. Her personal interest lies in gastroparesis, having not only conducted extensive research into dietary therapy for patients with gastroparesis, but also through a private dietetic practice where she works with patients at all stages of gastroparesis. Without further ado, please welcome Jessica Peters.
Thank you. And lucky last speaker of the day. And I think I probably won't take up the full 40 minutes. So that'll be good if there are some questions from the audience, then we can obviously go into all of that. So I just want to say thanks again for having me speak today, and thanks for putting on the day. I think it's been fantastic to have a room full of people all really interested in gastroparesis. And especially with, Jeff brought up the article about the disease prestige, and so I think it's great that we're focusing in on this condition. So, okay. So I'm trying to keep the talk quite practical today. We've obviously heard a lot throughout the day about the science behind gastroparesis and the science that informs the dietary modification. So I'll just revise, I guess, briefly what the evidence tells us, and then talking about all aspects really of the dietetic management. So looking at the nutritional assessment of the patient, and then the various stages of the disease. So looking at oral nutrition support, enteral nutrition support, and parenteral nutrition. And then talking also a little bit about additional challenges, so things like disordered eating and the relationship with food, which are extra challenges that we sometimes need to deal with in our patient group. Okay, so after everything we've heard about today, it's no surprise that patients with gastroparesis are at significant nutritional risk. We know that patients obviously have difficulty in taking enough nutrients across the board, macro and micronutrients. And a survey that we conducted, we sort of hijacked onto Simon's survey looking into the psychology of gastroparesis and added some dietary questions in there. And we had 187 respondents and found that the average BMI of the patients was around 25. And I think what that sort of demonstrated was that although we know that patients are extremely malnourished, often on the outside some patients may not appear malnourished, and I think it can lead to sort of an underestimation of the prevalence of malnutrition in this group, and it's really important that we don't underestimate it. There is a full range there. We had patients ranging between BMIs of 13, which is severely underweight, right through to 45. But what we found was that over a third of patients had lost more than 10% of their body weight in the past 6 months, which is really significant. So this is a group that are quite malnourished, and we need to appreciate and to address that. So, as I said, it's a macro and a micronutrient inadequacy, and a study by Parkman found that there was an average reported intake of about 1,200 calories a day in patients with gastroparesis. So that's really between about half to 2/3 of what an average regular person would intake over the day, so significantly restricted. And it is really hard to quantify what patients are managing to take in. I think sometimes there's perhaps under-reporting of intake because patients feel like they're having nothing, and they might be having next to nothing, but there's sort of a grazing throughout the day, and so it's really hard to recall what you might have eaten. So there is difficulty in quantifying it, and so probably the best way I'd say to assess the nutritional adequacy is really just by looking at weight history rather than trying to take a sort of quantify that intake. And then looking for clinical signs of protein deficiency and things like that. So looking at hair, skin, nails can also be other indicators. So micronutrients are also, of course, at risk, and that comes with the limited diet that patients end up on. And there's particular micronutrients, I guess, that are more at risk, and they're things like iron, zinc and B12, so nutrients that we find in meat products, which usually have to be restricted. Also, some of the fat-soluble vitamins, so vitamins A, D, E and K can also be quite limited because we are restricting fat in the diet. And it's also important to consider the impact of some of the medical therapies, so proton pump inhibitors that reduce the acidity of the stomach can inhibit the absorption of iron. And jejunal feeding means that we're bypassing the duodenum, which is the site of absorption of iron. So iron in particular is really at risk. And the recommendation there that I would have is I pop most of my patients just on a general multivitamin, and there are liquid formulations available if patients don't tolerate tablets too well. And perhaps performing micronutrient screens annually or more, as is dependent on the individual patient's risk. So going into a little bit of the science behind the modifications that we make to the diet. As we've heard about today, we know that fat, when it's released into the duodenum, triggers the release of cholecystokinin, which slows gastric emptying. And we know that fat is associated with increasing nausea in patients, and that effect really only applies to regular long-chain triglycerides in the diet, and it's not seen with medium-chain triglycerides because they are absorbed so rapidly from the duodenum. So MCTs can be a potential supplement that we can use to add calories to the diet. Osmolarity. We know that high osmolarity is associated with reduced intestinal motility, and so then being careful to avoid things that are too hyperosmolar. So that might include very concentrated fruit drinks, carbohydrate solutions, sports drinks, energy drinks, those sorts of things. And it also has implications on the type of oral and enteral nutrition support that we might choose, which I'll go into a little later. Texture, as we've talked about in a number of the talks today, smaller particle size improves symptoms compared with isocaloric solids. So blenderized foods, liquid foods tend to be much better tolerated. And fibre as well. So particularly insoluble fibre does delay gastric emptying. So we try and limit that in the diet. And again, I'll talk through a little bit more about the practicalities of that. And this is a graph of Michael's, which he also showed, but I think it just nicely puts it all into a nice little visual for us, just going through the different types of diets and how they impact on the gastric emptying. So we can see down the bottom that water is obviously the most quickly emptied out of the stomach, followed by low-calorie liquids. And then, interestingly, that high-calorie liquids are slightly better tolerated than low-fat solids, so indicating that texture is perhaps more important than fat content. And then finally, the high-fat solid meals taking the longest to empty from the stomach. So getting into the practicalities of what the dietary intervention looks like. Ideally, it is dietitian guided, just a plug for dietetics today. So from the study that we undertook, we found that 40% of patients had consulted only non-evidence-based sources of guidance for their dietary modifications, and that those patients were actually less likely to see symptom relief. And not only is dietary guided therapy more effective, but there's also a high risk of nutrition deficiency when patients are self-guiding their interventions. So they might reduce fat without replacing the fat-soluble vitamins, or cut out meat without replacing those sources of iron, those sorts of things. And there's also the issues of quality of life. So sometimes seeing a dietitian can enable us to perhaps think of foods that the patients haven't considered being able to include in their diet, so we can help with dietary variety and hopefully improving quality of life there too. So what does the diet look like? Overall, it's low fat, it's low fibre, particularly insoluble. So that means avoiding things like the skins of fruits and vegetables and seeds of fruits and vegetables, and anything particularly high in roughage like wheat bran and those sorts of things. But I think it is important to have enough soluble fibre in there to promote laxation and a regular bowel habit, because constipation negatively impacts on gastric emptying. So I really try and make an effort to include things like oats, soft cooked fruits and vegetables, and other sources of soluble fibre to help promote that. Foods should generally be semi-solid or easily broken down. So what I mean by that is that some foods which are solids break down really quite easily. So things like crackers, rice cakes, those sorts of things. So they are solid, but they sort of almost melt in your mouth and they're easily broken down by the stomach. And I find that patients tolerate those quite well, and it is nice to have something sort of solid to crunch on once in a while when the diet's otherwise quite liquidy. The liquids should be isoosmolar as much as possible. So as I said, avoiding things like energy drinks or hyperosmolar formulations. So I think it's important, as I'll talk about with enteral formulas, to try and avoid things that are too hyperosmolar. And limiting alcohol and carbonated beverages, which can impact on gastric emptying and satiety as well. But it also is important to adapt those recommendations to the patient. It's not a one-size-fits-all. Some patients I'll see that find that some things that I recommend that they avoid, they've actually tolerated quite well. Some patients, I saw someone last week that said to me, bananas are the devil. So, that's a food that would typically be generally well tolerated in patients with gastroparesis. So just sort of adapting your recommendations to suit the patient. And re-challenging too, so the symptoms can sort of fluctuate and come and go with time. And I think one of the downsides that can occur with following a restricted diet for a long time is that patients can develop a little bit of a food phobia with foods they've had terrible experiences with and that have made them feel quite unwell. So I try to just encourage retrying foods and that experience might just have been a one-off, or they might have been going through a particularly bad patch. So trying to see if we can, retrial things in a couple of months' time. We've also talked a bit about diabetic gastroparesis, and that maintenance of glycemic control seems to be quite important. And this graph was shown earlier, but just shows the difference in the half emptying time of the stomach between a blood glucose of 4 and 8 after meals. And, I think achieving a blood glucose level of 4 postprandially is probably next to impossible, but I guess it does indicate that perhaps aiming for a lower postprandial blood sugar is potentially helpful in the short term and probably the long term in terms of its effects on neuropathy. But that itself is really hard to achieve when you've got a population group that have very slow gastric emptying. It's really hard to then tailor their insulin therapy or their diabetes medications to match that sort of delay in the emptying and the absorption of the nutrients. So low GI foods, which we would generally recommend for patients with gastroparesis, may exacerbate the symptoms because they are by nature higher in fat and fibre. So I think it's really important to involve the patient's diabetes educator or endocrinologist so that you can try and come up with an insulin regime or a treatment regime that suits the patient best. Considering giving insulin after meals, so traditionally patients would have their insulin and then eat, but with gastroparesis the patient might not know how much of the meal they're going to get through, and also because there is that delay in absorbing the food, it might be better to give the insulin a little bit later on. And also considering the use of things like the dual and square wave bolus with the insulin pumps. So I've seen quite a few patients on pumps that can use functions that enable the insulin to be released over a much longer period of time, which might match the profile of their digestion a lot better. So I've just popped up some sample sort of meal plans that I might suggest to a patient just to give an idea of what patients might be eating across the day. So obviously this would vary quite significantly, but for example, breakfast might be something like some sort of soft porridge with low-fat milk and banana, or it might be a smoothie, or toast. Generally, I don't tend to recommend a lot of bread because it is quite thick and gluey, but I find that crisp toast can sometimes be well tolerated. Lunch might be something like a soup or some crackers with some avocado and tomato and tuna, or soft eggs are generally quite well tolerated. And then dinner, maybe something like some soft meat and some soft vegetables, or a slow-cooked stew type meal. So I tend to try and go for the sort of soft textures and things that can be broken with the back of a fork before we go down the path of a fully blenderized or vitamized type diet, and see if we can make do with that first, because it is obviously a lot more palatable. And then, of course, snacks, eating really regularly throughout the day. And unfortunately, because often the hunger cues are just not there, the patients are feeling full all throughout the day, we need to look at things like eating by the clock and really trying to get into a routine of having the regular intake throughout the day, which can be quite difficult. Oral nutrition support is sometimes needed to supplement the normal diet. And so I try and go for lower fat and, as I said, lower osmolarity formulations. So I try and stick to around the 1 to the 1.5 cal per mil formulations. I tend to find that things like the 2 calorie per mil are perhaps too high in fat. And you can trial the MCT supplements or additional MCTs if they're available. I guess the difficulty I find there is that a lot of those products are only available on the PBS for patients with things like fatty acid oxidation defects and short bowel syndrome, and they're hard to get for patients with gastroparesis, but it's something that you can perhaps look into. Homemade supplements as well. A lot of patients don't really find some of the prepackaged supplements too palatable for long-term use. So having a go at making up your own with smoothies, using protein powders, those sorts of things. Unsaturated fats I've put up there. We don't have really any evidence around it, but I just generally anecdotally have found that patients tolerate fats like avocado and those sorts of things a little bit better than they would some of the saturated fats like deep fried foods or butters. So that's something that can sometimes work well. And then trialling dairy-free options as well. Some patients do, for whatever reason, seem to do a lot better on dairy-free milk alternatives. But then, that's just a small subset of patients, and it doesn't hold true across the board. But just trialling those different things. For hydration, sometimes things like oral rehydration solutions or tea, water with lemon added, just things to sort of add a little bit of a variety to try and keep up the hydration throughout the day. And room temperature might be better tolerated as well. So sometimes very cold liquids can cause a little bit of a spasm in the stomach or the esophagus and can not be as well tolerated. One of the questions that I get fairly often is how to estimate requirements in patients with gastroparesis and how much should we be feeding and what's the sort of threshold below which we look at enteral nutrition. And I actually find it's probably not too helpful to estimate requirements in this population. I think it is really hard to estimate because there are a group of people that are perhaps not necessarily being able to be out and as active as the normal population, and so the energy requirements tend to be a little bit lower. And there's also a difficulty, as I said before, in accurately determining what they're currently taking in. So they might be grazing throughout the day and not report some of that intake, or might not realise that they're stopping their enteral feeds perhaps as much as they are due to symptoms. So really I just find that if the patient is losing weight, then we're probably going to need to try to bump up the calories, and if they're managing to maintain their weight, then we leave it as it is. And I think probably trying to keep it simple and not overcomplicate it by trying to use lots of equations that aren't very well validated in this population. Enteral nutrition, unfortunately, sometimes we need to go down that route, and generally jejunal feeding is used in preference to gastric feeding, and that's obviously because we're bypassing the stomach, and it also can improve glycemic control in some patients with diabetic gastroparesis because we are avoiding the delay, which means sometimes we can better match insulin to the food or to the enteral feeds. So usually what we do is try a nasojejunal tube first and then progress to a PEG with a jejunal extension or a jejunostomy tube if the jejunal feeding is successful. And as I said before, composition using sort of something like a 1.5 cal per mil formula is what I tend to go for. And again, I think I generally would advise to stay away from things like the hydrolyzed protein formulas, because they do tend to be a lot higher in osmolarity than your standard polypeptide formulas, and because there's no evidence to suggest that there's anything wrong with the enzymatic function of the patient. So there's no rationale for using hydrolyzed protein formulas. Avoiding things that are too high in fat, and again considering MCT containing formulas, and avoiding fibre. A lot of the fibre in the enteral feeds does tend to be quite high in fructans, and there is, considerable overlap in some patients with IBS and gastroparesis, and just encouraging bloating is maybe not something that we're wanting to do. My general regime is to start around, once the tube's inserted, start around 20 to 40 mils an hour and try and increase stepwise over a couple of days up to a maximum of about 80 to 100 mils an hour when we're feeding jejunally. I think much higher than that, and we start to run into problems with diarrhoea. Remembering to consider the risk of refeeding syndrome when we're initiating feed, so starting slowly, prophylactically supplementing with electrolytes and supplementing with thiamine. Limiting the oral intake initially to establish feed tolerance. So usually when we start patients on enteral feeds, we'll do it in hospital for a period of 1 or 2 days, and take the patients off oral intake and just have sips of clear fluid only. And the reason for that is really so that we can tell if the symptoms are adequately treated by the enteral feeds. And then we can switch over to overnight feeds after that. Utilising mobile pumps and backpacks to make things as lifestyle friendly as possible. So the backpacks and the pumps that we can get now are very small, very portable. And additional water flushes are often required as well, just to meet hydration requirements, particularly if the patients are venting large volumes out of their gastrostomy tubes. And in that case, then consideration of potassium can be really important too. So patients can lose quite a lot of potassium if they are venting a lot out of gastrostomies. And we've had a few patients come in with quite significant hypokalemia. So monitoring that is also important. And in that case, water flushing with things like oral rehydration solutions can also be a good idea, just to maintain the electrolytes. So parenteral nutrition is really a last resort, but sometimes it is unavoidable. And there are considerable risks of things like line infection. There are some risks of liver injury, and as Jeff mentioned before, it's a high-cost therapy. But it may aid in gut rehabilitation by enabling us to get the patient a bit better hydrated, a bit better well-nourished. So some patients might just get into a situation where they are so malnourished that we might be able to aim for weight maintenance with enteral feeds, but we might not be able to feed the volume required for weight gain. So sometimes bringing a patient in for a short period of time on parenteral nutrition can just enable us to get a little bit of weight on, get to a point where they're able to tolerate enough enteral or oral nutrition to maintain the weight. So it can be helpful in that way. And I do recommend maintaining a low rate of enteral nutrition for gut tolerance and for the trophic effect. So trying to continue trickling in 10 or 20 mils an hour, or continue with a small amount of overnight feeds, at least, for a few hours a day. I think that's quite important. And to keep re-challenging and seeing if you can keep bumping up the enteral feeds. Okay, and so I also wanted to talk about some of the challenges of the management of gastroparesis patients, and I guess there is a little bit of coexistence sometimes of eating disorders and functional GI disorders, and that's where we can run into a lot of difficulty in trying to sort of pick things apart. 98% of eating disorder patients fulfil criteria for functional gastrointestinal disorders as well. There is a lot of overlap, and it also works in the other direction as well. So dietary restrictions can lead to anxiety around certain foods. As I mentioned before, if patients are following a restricted diet for a long time and feeling a lot of exacerbation of symptoms from particular foods, then it can be really difficult to then for them to want to try those foods again, and we can end up in a situation where the diet is perhaps overly restricted. And so I think then it's, as I said, really important to try to reintroduce foods or re-challenge if we can. And there also is perhaps a small subgroup of patients that may have an underlying eating disorder that present with the symptoms of gastroparesis. And in that case, confronting it is sometimes not particularly helpful, and we run the risk of having patients disengage from the service because they may have had really bad experiences with eating disorder services in the past. So I think in that case, just trying to build a rapport with the patient, challenge any restrictions that you think might be illogical or excessive, and just reduce the nutritional risk. So trying to keep the patient involved, trying to get the weight up to a safe level as we can, and restore electrolytes, restore micronutrients, those sorts of things. And I think psychological support is also crucial, as Simon has obviously highlighted for us today. So I think that's about all that I really wanted to talk about, but I'm happy, as I said, to take any questions. I guess key points that I sort of wanted to highlight was that there is a significant risk of caloric, protein and micronutrient inadequacy in this patient group, and that's one of the major challenges. Maintaining the dietary variety and quality of life is another challenge that I think sometimes gets overlooked because we get bogged down in the detail of concentrating on the calories and those sorts of things, and always remembering that there's a patient there that just wants to go out with their friends and eat what their friends are eating, and so trying to come up with solutions for that side of things is important as well. And considering the relationship with food and body image. Assessing the nutritional status objectively rather than looking at numbers in terms of things like estimated requirements, and just acknowledging that there can be changes and fluctuations in the syndrome over time, and so retrying things. And having a little bit of a crash plan as well. So some patients might be doing really well and then might go through a rough patch with stressors, whether it's at home or at work. And so having a bit of a plan for, this is what you're eating at the moment, but if you go through a really rough patch and your symptoms flare up, we've sort of got a plan B with your diet and going to a more liquid or vitamised type diet if we need to. And, of course, the multidisciplinary approach in working with people like psychologists and doctors, diabetes educators. That's also very important.
So we're going to give you the chance to ask Jessica some questions. No doubt there'll be a few.
Hi. With regards to the managing patients with diabetes on pumps, in your experience, how long of the time frame do you set? Like, given the delay in gastric emptying, how many hours do you tend to use as a guide?
I think it can really vary depending on what sort of foods you're looking at. With liquids, I think liquids tend to still be emptied quite rapidly, so I probably don't tend to change them too much. But with some of the solids, delivering the insulin over a period of a couple of hours even, rather than sort of just over half an hour after a meal. Something like CGMS, doing the continuous glucose monitoring, I think is really useful. So getting them to wear the CGMS monitor for a couple of days and having a look at what their glucose does after meals, and then trying to match it to that is what I found probably to be the most useful approach. Yeah.
Which oral nutrition supplements are you using for top-ups?
I probably tend to mostly use something like Ensure or Fortisip, so just a standard 1 to 1.5 cal per mil formula, no added fibre, I generally find that's probably the best tolerated. And then I do use a lot of just sort of homemade, like encourage patients to make their own smoothies that then they can adjust to their own taste, because I find that you do tend to get a bit of flavour fatigue and patients getting sick of some of the pre-prepared ones.
With the juice-based supplements, are they too high in osmolality, even though they're higher protein but low fat? How do you find they go in the juice versus the milk-based supplements?
Yeah, I generally do find that the milk-based supplements are better tolerated, and I think maybe it is because of the difference in the osmolarity. And I also just find that the juice-based supplements are sickly sweet, and I don't find that the patients really like taking them as much. Yeah.
I was just wondering if there's any dietary modifications that help with any of the symptoms, such as nausea, bloating, fullness, like besides the small frequent meals to help with the early satiety. Is there any dietary modifications that help with the other symptoms?
Well, I guess all the dietary modifications are aiming to just improve gastric emptying, in the hope that improving gastric emptying would also reduce nausea and bloating and those other symptoms. Some patients, I think, can have, having gastroparesis doesn't exclude you also from having irritable bowel syndrome. And if I think there's an aspect of that, then I'm conscious that the diet is already so heavily restricted. I don't want to then put a low FODMAP diet on top of it, but I'd probably say, don't go overboard with onion, garlic, pears and apples, or something like that. And sometimes that can be helpful. Yeah.
Can you pass it on? Thanks, Jess. Really appreciate your talk. I was just interested in some of the practical strategies. You did mention about the soluble fibre, but managing that constipation and gastroparesis at the same time, I find really tricky. Do you have any thoughts on that?
Yeah, I think that is really difficult, but definitely important, because, I think the second the patient gets constipated, the gastroparesis symptoms just go through the roof. Yeah, it's a really vicious cycle. The main thing I focus on, as I said, is trying to maintain the soluble fibre while reducing the insoluble fibre, and maintaining a reasonable fluid intake as well. I also encourage the patients to be physically active as much as possible. So even if it's something like just going for a short walk around the block after eating, because just to try and stimulate the sort of muscle contractions and things as well. And then I then just send them back to Jeff and see if he can do something more about the constipation.